Welcome to our second Bhekisisa webinar for this year, during which we are going to focus on the lessons that we can learn from South Africa's national vaccine rollout for its planned National Health Insurance Scheme. I am Mia Malan, I'm Bhekisisa's editor. Now, in March 2020, when South Africa recorded its first official COVID case, all of a sudden, all public events and physical events could no longer happen the way that they used to happen. And during that time, we had national health insurance public hearings going in the country, and that also had to stop as a result of our lockdown regulations. And now it's more than a year and a half later, and the NHI processes are well underway again. And in May this year, the Health Department appointed a Deputy Director General to head up the National Health Insurance in the person of Dr. Nicholas Crisp, who we have as one of our panelists today. And Dr. Crisp is also currently heading up the vaccine rollout in the country, which puts him in a really good place to share lessons between the two, the vaccine rollout and the National Health Insurance. But we also have some really great panelists from other sectors in the country, from both the private healthcare industry and also civil society. We have representation from Discovery Health, from Section 27, from Afrobarometer, and also Business South Africa. And I'll introduce all these speakers as they have their turn to speak. I want to tell you a little bit about how our program will work. We will start off with a 15-minute PowerPoint presentation by Dr. Crisp, and he will summarize where we're at with the National Health Insurance and our processes, and also the lessons the Health Department has learned so far from our country's COVID-19 response. And then I'm going to ask each panelist a question to which they will have 5 to 6 minutes to respond. And then we'll move on to your questions and comments. We've received quite a number of questions from some of you when you registered. So I'll ask some of those questions and also some of the questions that you enter in the chat box on your Zoom screen. So if you wanted to follow Twitter, Bhekisisa will be live tweeting this event. And if you wanted to follow those tweets, our Twitter handle is Bhekisisa at Bhekisisa_MG. And if you wanted to live tweet yourself, we're using the hashtag Bhekisisa webinar. Just a note to the speakers and all the participants, please keep yourself on mute. And also speakers, only put on your video when it's your turn to speak or when we do the Q&A session so that we can save some bandwidth. And now we're ready to start. Let's start off with Dr. Crisp, who's going to give us a short overview of where we are at with the NHI and also the lessons we've learned so far. Before he starts, a little bit more about him. He is a medical doctor and also a public health specialist who has for many years focused on health management and consulting across Africa. And he was also the head of the Department of Welfare and Health in Limpopo from 1994 to 1999. And Dr. Crisp also led the establishment of the National Health Laboratory Service, where we get all our COVID test results from, and also the establishment of the South African Health Products Regulatory Authority that we hear about a lot now because they approve COVID vaccines that we need to use in the country. Dr. Crisp, over to you. Dr. Crisp, are you there? Dr. Crisp is online. I think there's perhaps just a connection problem, so we're just going to sort that out. Just communicating with Dr. Crisp to see if he's coming online because he is on Zoom here with us. It looks like he's just suddenly gone offline, so just give a second while he's coming back online. We're also just communicating with him via WhatsApp quickly. While we're waiting for Dr. Crisp, I'm going to tell you a little bit about the other speakers that we have that you may have seen when we promoted our webinar. We're going to have representation from civil society in the person of Umunyana Rugege from Section 27, who is going to talk about civil society's response. We're also going to have Sibusiso Nkomo from Afrobarometer, who is going to talk about survey results of a survey of what South Africans think of the NHI after COVID-19. And those results were actually released this morning, and he's going to share some of them with us. We also have representation from Discovery Health. And as we all know, Discovery has run some of its own vaccine rollout sites during the vaccine rollout, which also accommodated public patients. And we have Tebogo Paleng from Discovery, who's going to speak. And then we also have Stravis Nicolau, who is a senior executive at Aspen Pharmacare Group, but who is going to represent Business South Africa today, which has played a major role in our vaccine rollout to get business involved and work with government to get our vaccines rolled out. It looks like Nicholas Crisp is just come online again. Nicholas, can you hear us? Can you hear me? We've just seen him come on Zoom again, so we just want to make sure that he can hear us. He's just sent us a message to say he's just cut out and he needs to restart his computer. So that might take a little while. I wonder during that time, if we could perhaps then start with our second speaker so long, and that is going to be Afrobarometer about their survey that they've conducted about what South Africans think of the NHI. And that is going to be Sibusiso Nkomo. And Sibusiso is a former journalist, but today he's going to tell us about that survey, and he heads up strategic communications and partnerships at Afrobarometer. Sibusiso, you have conducted this survey in collaboration with the Institute for Justice and Reconciliation about just what South Africans think of the NHI and healthcare after COVID-19. Could you share some of your results with us? Tell us what people's perceptions of the NHI are at this stage, and also how do they feel? Is it a yes or a no for the NHI? Over to you, Sibusiso.
Thanks so much, Mia, and thank you for having me. I'm just going to share my screen quickly, just run through. Okay. So the survey that we conducted was between the 2nd of May and 10 June. And basically it's part of our normal surveys that we do at the Institute for Justice and Reconciliation, who's the national partner for South Africa. And basically we interviewed 1,600 people across the country. So it's nationally representative and with an error rate of 2.5 percentage points. But to save time, I'm just going to show you a few things, and we can take it. I can answer questions after. So one of the things that's quite important for people to understand is this is what people said, that the impact of COVID-19 on their families. So in 20%, about a fifth of South Africans said somebody in their family became sick with COVID-19. And 34% of the sample said that they lost some income, whether temporarily or permanently due to COVID-19. The other issue was about difficulty with complying with the lockdown. So our data shows that most people agreed with the government locking down to make sure that people were safe. However, when it came to actually complying with these restrictions, a lot of people, about 6 in 10, actually said it was difficult. The other questions we asked were about limiting democratic rights during a pandemic. And I think most of you will remember early in the lockdown, there were some issues around how soldiers and some police were acting. And so we asked whether people would be willing to allow the government to postpone elections or campaigning during the pandemic. And we see here a 2/3 majority said they would. Whether security forces would should be actually allowed to enforce the health measures, and a larger majority actually said yes. And what is worrying here is the question about censoring media reporting during a pandemic. So 56% of South Africans agreed to this. When it came to assessing how the government's response to COVID-19, you'll see there that 6 in 10 actually said the government managed the COVID response fairly well or very well. And they thought that the government also kept the public informed about the pandemic. However, we have some issues where only 38%, about 38% of South Africans said that they would not trust official COVID-19 statistics. And smaller amounts of people saying they would trust a little bit, somewhat, or a lot. And who was likely to say they'd get vaccinated? So we need to think back that this was between early May, this was May and early June. And at the time, phase 2 of vaccination was starting. And you notice here that much older people were saying that they'd likely get vaccinated compared to younger people, and also more people in rural areas. I think one of the things here, this flags quite something important, that the issue about trust and perceptions of trust and corruption in government are actually really having an impact on how people view these things. In terms of healthcare insurance, we asked people, so most people said that about over 70% said that they were not insured. And so we asked them, why are you not insured? And 45% actually said that the available options are too expensive. In terms of this affordability issue, we asked, what about the quality of healthcare? What should the quality of healthcare be based on in terms of you actually affording it? Actually, do you think that healthcare should be based on affordability, on what you can afford, but basically getting a different quality of services? And here you've got an equal amount of people saying they strongly agree and disagree. So this is something that would need to be unpacked some more. The other question is about investment in health emergencies. So should the government actually invest health resources and special preparations to respond to health emergencies like COVID-19, even if it means fewer resources don't go to other health services? And just about a majority agrees, but you've got 27% of people saying no. And one of the other questions we asked was about whether, so remember I said earlier, do you have health insurance or not? And only about a third of South Africans, less than a third of South Africans have health insurance, and the rest don't. But here you have agreement where people are saying that actually it is fine that actually, even if I have a health insurance or I don't, the government should make an investment in a pandemic situation such as this. And just the last one is, would the government be justified to levy taxes for the NHI, additional taxes? And 69% of people say that they agree with this. So I think in the bigger scheme of things, you see that South Africans want better healthcare, and they're willing to support measures that may bring that to fruition. Thanks, I'll stop here. Sorry, Mia, you're muted.
Sorry about that. Thank you very much, Sibusiso. I think that is a great introduction, actually, for Dr. Crisp's presentation, when he's now going to tell us how far are we with these things that some South Africans feel they really want and some are critical of. Dr. Crisp, we're happy to have you back, and we're ready for your presentation.
Yeah, thank you very much, and good afternoon to everybody. Apologies for that. It's very strange. Just when one's about to talk and your whole computer just goes black in front of you, it's a bit embarrassing. But we're back, and thank you very much for the opportunity. And thanks, Boo, for stepping up and filling the space. So I'll try and keep it short. I was asked just to do some introductory comments, and I thought what I'll do is just try and address 5 things briefly. Where's the bill in the process? What's the timeline for the NHI given what's happened with COVID? What has COVID taught us? And I'll just touch on a few of the things that I think are quite useful. And then what's the vaccine rollout specifically taught us about procurement processes, public and private working jointly together, and the public health strategies. And then what has PPE corruption taught us about procurement processes that we need to do differently when we get into the NHI? So I'll just do it at a very high level because we don't have a lot of time. So just where the bill is at the moment, it's actually in Parliament today. They are busy with the hearing of oral inputs. The bill was introduced to Parliament, as we all know, in August 2019, and it has been heard in Parliament, and there's been debates at Parliament level. And then there have been public hearings. The dates of those various public hearings around the provinces are listed from through 2019 into 2020. And as we all heard, in March 2020, we were just concluding the last of the provincial hearings when our Parliament was busy concluding them when the COVID epidemic arrived, and we have not been able to continue until recently. So we were told that Parliament received 64,000 written submissions. The majority are very short, just yes, no's, we support or we don't support. But there were 130 substantial hearings, which Parliament is busy hearing at the moment. And as far as I know, they're already past the halfway mark, if not closer to the 2/3 mark at the moment. So this is the dates on which the public hearings have been heard. You can go to the Parliament website if you want to see who heard when. Some people on this webinar probably participated and made representations to Parliament, and there were a whole lot more. I got some presentations overnight of those presentations which have been made during the course of this week again. And even today, as I say, as we sit here, there are presentations being made. So we've heard from the chairperson of the Portfolio Committee that he would like this process of hearings to be concluded before the end of this year, and that the rest of the process of evaluating the bill should be finished at the end of this year. In fact, it's still quite a long way to go because Parliament then returns comments. They debate and listen to those comments, and the Portfolio Committee puts the inputs together and returns them to the Department of Health for comment, and may suggest substantive changes or minor changes to the wording of portions of the bill. And depending on how much change is required, that will determine what happens next with the bill. It may be thrown out completely if there's complete disagreement with it. It may be that certain sections have to be revised, and then it's still got to go back into the parliamentary process. So the bill, to get to the point where we establish the public entity and start to set up NHI, is still some way away. So in terms of the timeline, so the NHI is just one of the tools towards reforming the health system. It's obviously a fundamental tool because it's designed to be a completely different financing structure from the way in which the health system functions at the moment. And it will be many years before the entire system is reformed. I mean, compared from where we were 20, 25 years ago when the new South Africa was born, or just a little bit longer than that, until now, it's a very different health system from what we had back then. And we've seen that it's evolved slowly over time. Some would say decayed over time, but certainly got complex and messy over time. We do need to distinguish between the fund as the financing mechanism and the services which need to be reformed as the delivery mechanisms for the health service. And perhaps just to highlight some of those in the few minutes that are available to point, we can direct some questions later. The health system needs public reforms, which include a lot of quality improvement programs, infrastructure improvement in a large part of the infrastructure of the public health system. There's a need for managerial autonomy in the hospitals for the NHI to be able to purchase from the public sector. And there are a whole range of other reforms which need to happen in the public health system. The private health system, there are a lot of reforms, but I think if we just look back and remember the health market inquiry, which was specifically looking at the private sector and competition in the private sector, is made a lot of recommendations, not all of which are necessarily directly related to the NHI or can easily be harmonized with where the NHI bill is going, but a lot of them are very pointed and require reform with or without where we are going with the NHI. There's also been a recent publication of the Certificate of Need regulations for comment. I know it's a short timeline, but it is out for comment at the moment, and it will affect the way in which the private sector evolves in the months ahead. So those are health system reforms, and there are many. But the health financing reforms are the ones that will be managed through the creation of the National Health Insurance. Even as we sit here now, the provincial equitable share formula is being reformed. Now, this is not the first time. The formula gets reviewed from time to time. It's the way in which the government allocates money to provincial administrations, and that from that pot, the provincial administrations or the provincial governments, actually through their legislators, allocate money to, amongst other things, health. And more or less 1/3 of what provinces allocate in their provincial equitable shares is allocated to health. There's actually quite a wide variance between the highest and the lowest proportion of the PES, which is allocated to health from one province to the other. The second health financing reforms, as you heard, I've now been appointed a couple of months ago, and we are busy with the establishment of the nucleus of an office. It's obviously still very small, being one permanent member and a couple of reorganizing within the National Department of Health of functions that will be transformed and become a permanent part of the National Health Insurance Office. That is happening at the moment. There have been meetings in the last 2 weeks to dot the I's and cross the T's for the submissions to the Department of Public Service and Administration. Out of that, there will be posts advertised for key positions. As I said, it's just a nucleus, and those key positions are, we hope, going to be the senior positions who will start to build teams and document the processes and start to do the draft regulations for consultation. That too will not happen overnight. It's going to take some time. Now, the National Department of Health and the provinces receive conditional grants and have done for years now. They've become quite complicated with many bits and pieces, some direct grants to provinces, some indirect grants through the National Department of Health. And it's quite difficult to manage all these many grants and try and understand exactly what they're trying to achieve in the reform of the health financing and, in fact, the health system. So there's a process of discussing with Treasury the reorganization and the consolidation of those grants. Then, of course, addressing private health insurance outside of the medical schemes. So the majority of private health insurance is through the Medical Schemes Act. But over the years, exemptions have been used and other pieces of legislation have been used to set up medical insurance. And one of the things we have seen is that it creates confusion for people in the public, and people are trying to claim for various things through this COVID epidemic that are not covered in terms, it's because the insurance they have is not medical schemes insurance, it's other insurance. And there is revision going on at the moment of the prescribed minimum benefits and some kind of harmonization to arrive at a single entry package. So just some questions about what have we learned and what are we learning as we go. One of the very important things that we've learned is having dual and divergent systems makes it extremely difficult to respond as a sector. So 18 months ago, when the first epidemic started, it was not first cases in the epidemic started. It was not possible to synchronize any reporting of test results, disease, deaths, beds, availability of space, nothing. Everything was captured by 9 different provinces, different parts of the private sector, and extremely difficult to integrate. So that has really come together to a point where we have common dashboards, everybody is reporting into common data sets, and the integration of the data makes it possible for us all collectively to begin to plan a lot better. I'm not saying that we are all the way there, but certainly we're in a far stronger position than we were. There are very complex systemic arrangements for financing that makes it extremely difficult for us to plan and manage a response. And we've seen that in the initial stages when we were trying to contract from the public sector to buy private sector capacity in the first wave. And you end up having to have an agreement between a provincial administration and 5 different subcomponents: the hospital, the doctors, the x-rays, or the radiology, the laboratory, and the other supporting structures, all separate parts of separate contracts. And to duplicate that or replicate that across 9 provinces as well. Very complex arrangements to try and manage and to try and understand. We've also seen that the countries that have national systems, and they're all different, but they are national systems where there's a lot of sharing of the data and one common platform on which to deliver the health system. They were able to respond far quicker to emergencies. Some of them have made the problems for themselves with other decisions that they've taken, but generally it's much easier to respond if you have one system, which I suppose is common sense. The fourth thing that we learned is, despite the differences that many of us might have and might have had in the discussions prior to COVID, it's actually not that difficult to work together. You have to put your mind to it, get around the table, agree on the common starting points and build from there. But it's not that difficult to get to do things together. The one common database is going to be the make or break of a health system. We need, in order to build a coherent health system, to have the data that allows people to move within the system. So we talk about patient record portability, but we also need to be able to plan amongst ourselves. And during this period, we built the DATCOV system between the public and private and across the provinces, where we're looking at tests, beds, cases, and the reports that you see come from the data of this system. The electronic vaccine data system for vaccination and its many components that deal with registration, scheduling, and all the reporting that goes on, together with the master facility list, the site management, etc., is one single system that's used by the whole public and the private sector. Likewise, the stock visibility system. It's used by both the public and the private system for vaccinations. And all of this makes it much easier for us to plan together and to respond very quickly. So what did we learn about vaccines? Despite what some negative commentators have to say, the contracting and the purchasing of vaccines is in a global market that we sit with at the moment, is such that suppliers do not supply to anyone other than a national government. So it doesn't matter how much posturing either a private provider or a subnational provider in any country makes, they don't sell to subnational entities. They sell to countries. And competing in this global complex supply environment is way more difficult than any of us had ever imagined. We sit, unfortunately, as South Africa, between the first and the third world. And so we neither benefit from the advantages of having lots of money to procure on the open market, nor being one of the favored poor countries who are able to participate in the collective purchasing through the Gavi system or through COVAX. We do, in fact, buy from COVAX, but we have to buy. We don't get anything free there other than some donations, which we are now starting to see for the first time. We know that price setting is extremely difficult in this space. We have been forced into an arrangement, which I'm actually quite excited and happy about, of having to have a single no-fault compensation scheme and fund. We have a common supply tracking mechanism, which is able to limit fraud and corruption, because you can see very quickly any deviations. It's very hard to hide in the space that we're working in at the moment. And the quality control is actually very easy, because you're dealing with one big contract in one place and you can see the documentation. It's not split into lots of different places. The security, the control laboratory, the distribution is very carefully synchronized and well managed with a small number of people who are able to see all the bits and pieces at the same time. I know some people might regard that as making you vulnerable, but in fact, we find that it works very quickly and smoothly because of that. And I think we've seen that we've been able to ramp up quite fast because of this. But it does require commitment, close cooperation, setting aside of differences, being vigilant, being in the same room, in the same space, even if it's a virtual room. And the government and the private sectors, although we have different roles, often have complementary roles in providing healthcare. And right now, in this particular environment, it's to vaccinate as many people as possible. And as long as we don't try to do one another's jobs and we stay to our lanes, things actually go very smoothly. So my last comment is some more big and smaller lessons about PPE. This was, for all of us, a disaster. It was an embarrassment, and if we've done anything, we need to learn that this is exactly how you don't go about procuring anything ever. The way that the tenders in the government space were opened and the way in which the control was moved out of a previously functioning system, even with the good intentions that it had to try and make it more flexible, was really a disaster. And that central databases do make the products easier to control, the quality control on the products, and to manage the prices better, instead of having everybody selling a little piece like on a street corner and sort of rogue trading all over the place. We've learned a lot of lessons about how not to do things. The Office of Health Product Procurement in the NHI is envisaged to play this role in the future. It is not going to buy anything. It is the place where the products are determined that the fund will be using and be authorizing the purchasers to purchase at whatever price is set as the central standard price. And we hope that over time, that when enough of those products are there, it will stabilize the demand and supply, and everyone will be able to anticipate and know what they are dealing with. So I think my last comment is that I think we have witnessed human nature at its absolute worst and at its absolute best during the pandemic. And my wish is that we learn to moderate and get rid of the worst, and that we capitalize on the best that we have seen as we work together going forward. Thanks.
Thank you very much, Dr. Crisp, for that great summary, but also thank you for being so honest about mistakes that have been made and the lessons that you've learned from that. We're going to hear from Umunyana Rugege now, who represents civil society. She's the executive director of Section 27, and she's also a human rights lawyer who has led health-related policy development and law reform for particularly access to healthcare for vulnerable groups. Now, Umunyana, we've heard from government, but we also know that civil society has consistently raised some concerns, and there has been a renewed interest in how the NHI fits into the puzzle now, particularly within your sector. Can you bring us in the picture? What are these connections and how do we make sense of them?
Thank you so much, Mia, and thanks to my fellow panelists. I think what Dr. Crisp has said is really very honest, as you say, and open cards. And I think what we have seen is that we need more of that, actually. What we need is greater transparency from government. And I think one of the things that we fought for very early on in the pandemic was for just open cards. What is the position? Share the MAC advisories, share the information widely, have press conferences regularly. And I think that when we talk about universal health coverage and we talk about access to healthcare as a right in South Africa, you know, there are other rule of law principles that have to apply in NHI, and that we saw some of in COVID, like transparency, but in other things, like, for example, participation of civil society in decision-making simply wasn't there. It was very unclear who was making decisions. As I say, there was no access to the MAC advisories on which the department was and the government was basing decisions on the COVID response. And for me, you know, seeing the development of more transparency, we could then have more accountability. You'll recall that at the end of last year, we were trying to find out if there had been any negotiations on vaccines. And there was a great deal of public pressure that was brought to bear on the Department of Health to say what it is they were doing in relation to procuring vaccines that were at that time becoming available and coming online around the world. And South Africa seemed to be lagging and was actually behind the queue because the negotiations clearly had started late. So that need for just playing open cards, as Dr. Crisp has just done, and taking the country into the confidence of decision makers is really paramount. We're in this together, right? We all are here because we want to see the improvement of health systems. We want to see a more equal society and certainly a more equal health system. Now, one of the things that became very clear during COVID was the extreme levels of inequality in our system. And we at Section 27 always talk about the reflection of the inequality in society in the health system. It is deeply unequal. We know that only 17% or so of people are able to access private healthcare services, and the majority of the population access a very under-resourced public sector. So when we talk about how we respond in emergencies, we have to think about the investment in those public health systems. We've been talking about it for 2 decades now. We've got to see the investment actually becoming effective. We know that the NHI pilots and the money that's been poured in from Treasury into the health systems to try and figure out how to pilot NHI, to try and do some kind of improvement, has really not come to effect. We've not seen improvements, and we've not seen the effective use of available resources to be able to address the deeply unequal health system. And I think the inequality in our country has become so stark. You know, we have 18 million people who are on social assistance, who are accessing grants, and that may be growing. So we really need to bolster investment in our public health system. I would also like to say, just, you know, when we look at the centralization of procurement, that's one of the key kind of examples of what will happen in NHI, which is that there will be a single payer. And we saw that as Dr. Chris said, the centralized procurement and rollout of vaccines was an example of a large health program that is based on need and not the ability to pay. And that is what universal health coverage is about. And we can't disagree with that. What we need to think about is, how do we make sure that there's consequence management inside such a centralized system, that there's governance that the public has trust in. I think what Afrobarometer says is that there is a trust deficit. We've got to address that trust deficit. There are a lot of people in this country that are really want to see national health insurance. They want to see universal health coverage, but there's also a deficit of trust, which the government has to address whilst bringing into effect any of these programs. I'm sure that my other panelists will talk more about the private sector, but that was another example of coordination that will have to take place under NHI. And I think what is really critical is to see the health market inquiry recommendations being taken seriously by the National Department of Health. We're not seeing, there are no resources being put into the implementation of those recommendations by the department, as far as we know. The Council for Medical Schemes has done some work, the Competition Commission has done some work, but there really needs to be an investment in making those recommendations work within the private sector. And that really is about making the private sector more equal. We are very cautious about the example of Kenya, where because there was no real public sector, there was no high standard in the public sector, state funds were then poured into private entities to be the providers in Kenya. So we don't want to see that. What we want to see is a more equal system across the board, but that also requires an investment in ensuring greater equality in the private sector. I'll stop there, Mia.
Thanks very much, Umanyana. And I'd like to remind everyone that if you have a question or a comment, please use the chat box here on Zoom and post it there. We are keeping an eye on it. And I would also like to point out that we're going to move to the private sector now, but I would like to let you know that we have asked all the major hospital groups in the country to participate today. And they were concerned about participation because of the Portfolio Health Committee submissions that Dr. Chris mentioned. So they felt they didn't want to speak before that. But Discovery Health has agreed to participate and has been very brave, I think, to do that. And we have Tebogo Paleng from Discovery Health. He is the Chief Strategy Officer, and he's also a medical doctor who has worked in both the public and the private sector. And he heads up policy issues at Discovery Health in many respects. So Tebogo, we've heard about trust deficits now in central procurement systems and transparency. And Discovery has been one of the private healthcare players who has been running vaccine sites, rollout sites in the national rollout, and who has also accommodated public patients. And who's also have had to deal with procurement systems, so procuring vaccines from government for the sites. I would like to know what lessons you have learned about distribution change, working with government and procuring that you think can be applied to universal access to healthcare in South Africa.
Thank you so much, Mia, for the opportunity and the invitation. We're really delighted to participate. And I'll do my best not to offend the deputy DG in the room. So I think just to start with a bit of reflection, I think we've had a lot of challenges, and the missing story is behind the scenes, the struggles the Department of Health has had to face, and the government in the background. Nick alluded to these, but I think he's obviously not sharing the full detail. It's been very difficult. In the same period, I think the challenge of these recurrent waves and the impact of the pandemic on just the social and economic impact of the pandemic has been, it's clear to all of us. We have these non-pharmaceutical interventions plus the social restrictions, which do work, but they're not sustainable in the long term, very disruptive to societal and economic function. We have a common goal now, which is very clearly articulated: get 2/3 of the adult population vaccinated against COVID. That's about 40 million adults, and that's what we're working on together. And in designing and developing this program, supporting the National Department of Health, through the funding mechanisms, the access to stock, procurement, distribution, down to how vaccines will be, administered, the pricing of it. There's lots. I mean, even the modeling of the mass vaccination sites for the Department of Health. And down to the population risk stratification to say who goes first in the list and what's the expected impact. There's been, I think our assets during this whole time have been, we have a great sense of hope as a country. And we generally have maintained an optimistic outlook through all of this. The Department of Health has a very strong team in our view, very, committed as well. And they've played a very important stewardship role and coordination role for all of us. The social partners have been willing to come to the party: labor, government, private, business, and civil society. And there's been this great spirit of working together in a crisis. Fast forward to the vaccine program now and where we are today. I think it is the most important health and socio-economic intervention of our time. I think we mustn't lose sight of that. And the solidarity, I think, goes beyond just the planning and development. I think if you look at capacity as well, the private sector currently, public sector, has the ability to deliver just over 200,000 vaccine doses per day. And the private sector, 120,000 doses per day. So it's a split of about 63%, 37. We've, as a country, delivered 6.8 million doses so far. That's just under 7 million. We're 17% of the national target, right? Doesn't sound so great, but actually, if I tell you that in the first 2 months, South Africa, with all our problems, the late start and everything, but if you just take the first 2 months of the program, we've actually done better. If you take vaccinations per 100,000 lives, we've done better than countries like Australia, Japan, New Zealand, Germany as well is in that list. So we actually, I think, with all the problems, are not doing too bad. The flip side of that is there's still 33 million people to vaccinate, right? So daunting, I think, if you mention it that way. And what it actually means in practical terms, if we want to get to the end of the year and have vaccinated the 40 million, we've got to do the same amount of vaccinations, almost 6.5 million per month, 5 months in a row, until the end of the year. It's not a small thing, and it's going to require coordination and all hands on deck, public and private sector. The good thing is to do that actually on a daily basis. All we need to do is achieve 300 to 350,000 vaccinations per day. If we hit that mark daily for the next 5 months, we'll get there, right? And there's no vaccine supply issue, at least at the moment. There's about 25 million Pfizer vaccine doses coming in over the next 6 weeks. There's, I can't remember, probably 9-10 million J&J over the same period of time. So there's none of that, and capacity I've just mentioned we do have. So we must just get on with it. I think it is actually possible, despite what it sounds like. From a discovery point of view now, 14,000 vaccinations per day through 9 vaccination sites. That's been our contribution so far. It represents, I think, about 5% of the national vaccination load. We'd like to be at 10% with our partners. So even for us, I think there's still this aspiration to do more and to support the government. Interesting is that 25% of discovery clients are actually accessing their vaccinations through the public sector, right? So that's quite interesting. 25, maybe even a little higher than that. But if you take at the discovery sites, 60% of the vaccinees are discovery clients, 23% are non-discovery insured clients, and 17% are uninsured. That uninsured stat, I think about a month ago, was sitting at about 4%. So you've seen this shift where people are crossing the lines, and it's actually fun to watch, and it's really beautiful, I guess, for the country. It's public sector patients accessing care and services in the private sector, and you get discovery, other insured patients accessing care in the state. There's a beauty in that. How is it possible? I think the collaboration and cooperation that Dr. Chris mentioned is playing out. I think there's so many working groups and so many meetings, actual working meetings, they're not just talks, with the DOH, with Treasury, medical aid associations, regulators, healthcare providers, and there's this constant spirit of information exchange and ideas exchange and problem solving. The vaccination sites, from our perspective, we've done a partnership with the Western Cape government. We've got a mass vaccination site in Cape Town. We've been since approached by the Eastern Cape and the KZN government, so we're working with them on setting up mass vaccination sites in those provinces. There's also employer vaccination programs. The educators in Gauteng, the Department of Higher Education, Department of Social Development. Infrastructure, I've mentioned, the 9 vaccination sites. We've got a dedicated leadership team on our side, 200 new employees, young people who've, in this economic climate have been able to find jobs, and they support and work in the discovery vaccination sites. It's really beautiful to see. And then there's the system integration between kind of what we do on our side and the link into government's EVDS system and others, So layer by layer, you're seeing these links between public and private, which is critical. So to answer your question, I hope I'm not too far over time. The key lessons, I think, the takeaways for us, the parallels are interesting to watch. If you look at the NHI white paper and the NHI bill, the preamble of the bill, the policy objectives and the social solidarity principles articulated in there are playing out, I think, through this period and this program in particular. The HMI kind of operational reform recommendations, I think, are also playing out in a way. You've got this multi-fund kind of sourcing of funds. You've got purchasing between, single purchaser to source the vaccine, but actually, you've got medical schemes effectively purchasing vaccines from the government, and the delivery mechanism, across the public and private sector. And I think it demonstrates to us that a lot is possible. You actually, just given what we have today and the state of our laws and the framework today, there's still so much that we can do together before you even go through these massive changes. It's not to say those changes are not necessary. There's a good reason why they should happen. It's gonna require, I think, a permanent state of public-private cooperation. We probably need a whole discussion on that. So it's not just during a crisis. It needs leadership, inclusion. Minyana was just alluding to that. Governance, transparency, and systems of accountability. So we hold, all of us accountable to delivery. A common vision is helpful. This objectives that are clearly articulated with targets, timeframes. It's actually quite interesting and to see that. And I think the lesson in the NHI implementation should draw on that. It's very important to articulate clearly what the goals are and set clear milestones and targets over time so that we go step by step and achieve that. We pool our resources. Data. I think we need to invest in data assets. They allow us to make data-led kind of informed policy decisions, informed operational decisions as well. A simple thing, matching capacity within the system to this whole demand and supply equation. It's been quite interesting that we're able to, in a very fleet-footed way, work through that with the National Department of Health. Open communication is another thing, and a spirit of sharing of ideas and information. And I think lastly, just as a parting shot, for me, this whole thing has demonstrated the importance of a well-functioning health system and its impact on economic performance and economic prosperity. Part of the reason there's such a big fuss around getting the health system to work is because the health system is a big contributor to economic performance. And we're seeing it now with COVID. And the returns, I think, will come to us in due course. Yeah, thank you. So I'll stop there. I hope I've shared enough, and I hope the DDG is not too unhappy about our contribution. Thank you.
Thank you very much, Tebogo. Our last speaker is Stravos Nicolaou. He is a senior executive at Aspen Pharmacare, which we heard a lot about this week when Aspen released some J&J doses that they filled and finished that will be used in South Africa. But Stravos is representing Business South Africa today, where he is a member of the steering committee and the chairperson of the Business for South Africa Health Work Group, which has worked really closely with the health department on the vaccine rollout. And there's really been a lot of collaboration between businesses in South Africa and the health department. So Stravos, I would like you to expand on that. If you could tell me, for instance, Discovery Health has just mentioned, Tebogo, that we see an increase on their sites, at least, of public patients also using private sites, and that there is now a sort of like a collaboration in that respect. And how do you think this model can be applied to universal access to healthcare in South Africa? And do you think the vaccine rollout has shown us that private healthcare service providers can indeed work with the government and that differences can be put aside?
Right. Mia, thanks very much, firstly, for the opportunity. And in the second instance, may I also thank you and a number of other colleagues that I've noted on this call, Pat Sidley and others from the media, Tamar Khan, there are many of you on this call. I think let us thank you for the role that you're playing in what is arguably the most challenging environment that we have faced politically, socially, economically and from a public health perspective in our country. Of course, opportunities like this are important in that they, of course, provide additional information that is important to keep the public abreast of, and to try and assist the narrative, an accurate and concise narrative. And an accurate and concise narrative, of course, will help the overall effort, a national effort around rolling out as many vaccines into as many South African arms as quickly and as swiftly as possible. It's only through that type of drive and that type of common purpose that we will get ahead of this pandemic, eventually get on top of the variants and begin to open up our economy, which, as we know, is in distress at this point in time. So let me answer your question, Mia, that you've posed to me. I'm going to answer it in three parts. Firstly, let me express the position of business with respect to national health insurance. Let me start there. Organized business in South Africa supports universal coverage and understands the positive benefits that universal coverage, true universal coverage, would derive both from a productivity perspective, both from a perspective of enhancing social fairness and further developing social security in our country. And of course, there is the human dignity element, which our colleagues from Section 27 have been very explicit about on this call, and which we wholeheartedly support. We also realize as business that the achievement of universal coverage can be advanced and or achieved in various ways. We understand to get to the promised land of universal coverage, of course, requires investment in infrastructure. It requires further human resource mobilization. And of course, as Nick indicated earlier, NHI is a financing arrangement, and there are various financing options that can be applied in pursuit and or achievement of universal coverage, universal healthcare coverage. Of course, there's also and continues to be, and the vaccine program has highlighted this again, there are significant gaps between rural and urban areas in our country. But business believes that, as I indicated earlier, there are various ways of achieving this. We tend to favor a multi-payer, multi-procurer system for a whole lot of reasons, which we don't have time to unpack on this call, Mia, other than to address one of the aspects of that. And let me move into the second of the 3 points I wanted to make. Let's analyze and interrogate the collaboration that has taken place between the private and the public sector in rolling out what is, without doubt, the most important both public health and social program that our country has embarked on since 1994, and that is, of course, the vaccine rollout program. It would not be an understatement to say today that there's probably nothing more important in our country right now than efficiently and effectively rolling out the vaccination program to the desired between 35 to 40 million citizens that we've identified that would take us to herd immunity. I don't want to unpack herd immunity and what it means on this call. Let us just say the desired objective is to reach an epidemiological endpoint. We shift from an epidemic to an endemic, which is a lot more manageable. And that is the desired effect that we all seek. It's also going to take, as I said, 35 to 40 million. When I say citizens, of course, there are non-citizens that also need to be vaccinated and come into that equation. So if that is the stated objective, let's just analyze where we are right now. And probably the best analysis is, at the moment, I'm speaking to Nick more times in a day than I speak to some of my Aspen colleagues. So that demonstrates the private-public collaboration that is taking place, just at a very rudimentary and or cursory level. But let me unpack that a little more. When we commenced the rollout in our country on the 17th of May, and I'm discarding, for obvious purposes, the Censoring program, which of course realized almost 500,000 jabs in arms and preceded the 17th of May mass vaccination launch in our country. So that was, if you think about it, a mere 10 weeks ago. Sorry, and I meant Mia, not Mia, as in your name, Mia, right? Okay, because what I do appreciate about you is just how analytical you are around things. And I'm going to be a little analytical here as well. So when we launched 17th of May, we were doing 0.025 vaccinations per 100 citizens in our country. Last Friday, we touched 3. So that's a 15-fold increase, 3 per 100. So you can work out a 15-fold increase over, roughly a 10-week period is quite an aggressive ramp up, and one that many people thought we wouldn't achieve or get very close to at all. I keep lamenting that some of the analysts were saying in April that at the rate we were vaccinating at, it would take us 23 years to achieve our 40 million vaccines. I mean, that is a very insincere way of presenting it, because when we were in the Censoring program, we started with 17 sites. It was never the intention that we were going to stay put on 17 sites. We all knew that was an implementation study, and to draw any comparisons and or conclusions out of an implementation study is not only duplicitous but inaccurate. And I think the facts today are bearing that out. So we are in a much better place, and we're only in a much better place because we've had, in my view, an unprecedented collaboration between the private and the public sectors. This unprecedented collaboration has taken the form and shape of an integrated approach where you have a single program for the country. It is led by the National Health Department, and business and all the private sector work alongside government, hand in glove, and in that integrated approach, I should rather say, we support, assist, and where necessary, complement government in this all-important rollout program. So this integrated approach has, I think, very clearly demonstrated what can be achieved when you get the private and the public sectors working alongside in a proper integrated fashion. And I think that where we're not working this closely together, I do not think we would be achieving the 15-fold increase that I spoke about. And of course, that 15-fold increase over that 10-week period has been achieved in a vaccine-constrained environment. We continue this week to be vaccine-constrained, and I think we move into a much better vaccine supply environment from next week onwards. And that is when we can start talking about ramping up even further. I think you've heard some of the numbers, Mia. The target of 300,000 that the president has set for the country is easily in our sights. And I think, in fact, in Business for SA's presentations over the past few days, it is not beyond the realms of possibility, if all the stars align, of course, that you can breach the 400,000 mark. A sustained point.
I'm sorry for interrupting you, Stravos. That is a great summary of how business is involved. I'm going to give you 1 more minute to end off, and then we're going to go to questions and answers, because I'm sure there's many people who want to hear how you respond to some of the questions.
Okay, so let me move to my third point. It's the third and concluding point that I wanted to make. Okay, so why is there confidence that we can work together using the vaccine rollout program as a torchbearer, if you will, for why we can work together into a future healthcare system? We might have a difference with government around a multi-payer, multi-procurer system, as I spoke earlier, but that doesn't mean that you cannot work together to achieve that goal of universal coverage. So let me just conclude with some of the elements of this collaboration and why it gives a lot of confidence moving into the future. So first level we've collaborated at is information sharing, data, dashboards. So we're working off one single plan, as I said, one single vaccine plan with one single dashboard across both the private and the public sectors. And Nick alluded to that as well earlier. It is possible to get to that point. Many doubted we could get to that point, and I think they've been proven wrong. So it is quite possible to get to that point. Secondly, we have set up coordination and or collaborative structures, the most prominent being what we call the Joint Oversight Committee. So the Joint Oversight Committee is a five-a-side. There are 5 people from Business for South Africa, and there are 5 colleagues from the National Health Department. The JSOC, as we call it, is chaired by the Director General of Health, Dr. Buthelezi, and we also have representation from Labour and National Treasury on that structure. That structure works through policy inputs and also any high-level operational issues that are seemingly unresolvable need to be resolved so that you can continue operating seamlessly. So it is possible to put up these structures and for them to work efficiently and effectively. Lastly, on logistics and capacity, infrastructure, we've been able to allocate both public and private sector infrastructure in order to ramp up this capacity. And we've done this not by collapsing the private sector into the public or vice versa. What we've done is we've harnessed the capacities that exist across private and public sector. So those that exist in the private sector now take on uninsured patients. So uninsured patients can now turn up at any private sector facility, Discovery, Dis-Chem, or any other facility for that matter, and get vaccinated. And there's an arrangement that's been worked out with the National Health Department for these patients to present and for these private sector providers to be paid for both the vaccine and the administration fee for the administration of the vaccine. Okay, that was my last point.
Yes. Okay.
That was my last point. Thanks very much.
Thank you. That's ending it on a very practical note of what can actually happen when we work together. We're going to move on to questions and answers now, and also to comments. I would like to read one comment that there's been on Twitter and also on Zoom, which says keywords that are coming through from all speakers is collaboration and cooperation. Healthcare in South Africa should no longer operate in silos. We are seeing just how important the links between public and private sector are and the positive impact it could potentially have. So I would like to thank both Sibu and Dr. Chris for answering questions that were asked on Zoom, and they answered it in a written form. I'm going to read 2 of the questions and the answers just in case any of you were wondering about that, and then we're going to go on to some of your questions. One question from Patricia Sidley was, I would like to know if there were any incidents of corruption or similar in the procurement of vaccines. So were there corruption similar to the PPE corruption in the buying of vaccines? And the answer by Dr. Chris was, so far, no corruption in vaccine procurement. there's nothing that we are aware of. We as the health department, of course, we're remaining vigilant. We are aware of a few incidents of people who are alleged to have sold vaccines, but law enforcement is busy with those. And then one more question, that is from Marika Keller, that is, how far is the government in setting up the no-fault compensation scheme and fund? And where is the money coming from for the scheme? For instance, will departments be getting budget cuts to fund the scheme? And if so, which ones? And the answer by Dr. Crisp is so far no corruption. Sorry, that is again just the corruption procurement. Dr. Crisp, I actually have the wrong answer here that was copied and pasted. Can you answer that question for us? How far are you with setting up the fund and where will the money for it come from?
Okay, thanks very much. Thanks, Mia. So the fund has been established. There's a judge been appointed, and there are some staff that have been allocated to him to assist with the setting up of the administrative structures. There's a thing called AFI, Adverse Events Following Immunization, which is a standard protocol that is used around the world for reporting adverse events following immunization. It's always been there for childhood vaccines, and that has been extended to these vaccines that we're using for the COVID response. The teams in the provinces and at national have been increased to deal with them. And the process, once any investigation into an adverse event, especially the serious adverse events, ends up as once there's causality determined, then that's what ends up in the no-fault compensation scheme. In terms of the funds for this, it's different money. It was budgeted for by Treasury without taking money from the provinces. But obviously, it's not cash that's put in a fund. It's just money that's available should there be claims. Thanks.
Thank you very much. I'm going to stay with you, Dr. Crisp. There is a question from Corruption Watch from Kirsten Pearson, who is asking, is the Department of Health going to address the concerns that activists have raised about the proposed governance arrangements for the NHI fund? And also, if not, you are condemning the NHI to certain corruption issues and setting it up for I told you so from naysayers. So are you addressing those concerns that there are about how the fund will get governed? And I assume also about all the powers that the health minister specifically will have when it comes to governing anything relating to the NHI.
Okay, so unfortunately, because this is in Parliament, I'm not allowed to comment on it. Whether I have a personal opinion or whether the department has an opinion doesn't matter at this point. What happens is that all the very important submissions that are being made at the moment, some of them have addressed this issue and have been raised. Many were raised with us, including by Corruption Watch. And what happens now with the process is that those get submitted back to the department for our response and back to government for government's response. So unfortunately, once the matters like this in Parliament, now that I'm in an official capacity and no longer a consultant, I'm unable to respond at this time, as they say. Thank you. But I mean, I can't say we haven't noted. Of course, we have noted, and we know it's a serious concern. Thanks.
Thank you. There's a question for you and also for Umunyana from section 27 that relates to how will we address healthcare for undocumented migrants in the country. And I guess that relates to both the vaccine rollout, where we're not quite yet sure how will we serve people who don't have the ID documents that the EBDS requires you to have, and also how will we do that with the NHI, because in the current bill, not all the needs for those people, that group of people, are addressed. Perhaps, Umunyana, we can start with you to just summarize the concerns around this, because I know section 27 is very passionate about that, and then we could get Dr. Chris to respond.
Indeed, I think it's such a critical question. I think for health services more broadly, there are several health services that are available to migrants, asylum seekers, refugees, and others, including maternal services, childhood vaccines, that kind of thing. So there's a recognition that there should be a level of universality around health services and to not exclude people unnecessarily. So it should be based on need. We know HIV services, for example, are available across the board. because we know we're dealing with infectious diseases, and that these diseases don't respect whether you're a citizen or not a citizen. We also know that in terms of Section 27 of the Constitution, that it talks about everyone having access to healthcare services. That is the guarantee. That is what we are committed to as a country, to ensuring equitable access to affordable healthcare services for everyone. And this is why the provision in the NHI bill is so confounding. Excluding asylum seekers from NHI is problematic. I think we must reject discrimination on the basis of nationality or citizenship. We have to be more progressive than that. And we know that there is a potential problem constitutionally with the provision of the NHI bill. And so we would hope that Parliament recognizes that. There are many organizations that have raised it in their submissions, and it should be dealt with and simply removed. In terms of vaccine access as well, we are unclear what is happening with undocumented people who can be citizens of any country, including South Africa. So let's get a very clear undertaking from national government that people without any documentation should be able to access, and we need the information about how they will be able to access a vaccine.
Dr. Crisp, how are we going to give vaccines to people who don't have IDs and who are undocumented? And also, how are we going to handle this issue with the NHI?
Yeah, okay, so thanks very much. And I mean, those are really important questions. As health practitioners, we are interested in everybody. We're not particularly interested whether you're documented or not documented. So we have been working on a solution during the first few, what we call phases of the vaccine rollout. And it will be part of phase 4, which we haven't entered yet. So the objective is to find a way to provide an ID. Now, that's easier said than done. So what happens is the Department of Health works very closely with the Department of Home Affairs to identify all of us. And they have the primary responsibility for an identity. So we will use the identities that are provided from Home Affairs, whether it is an ID, whether it's a passport, whether it's a foreign passport, an asylum-seeking number, refugee number, whatever. The problem remains for us as healthcare providers is how do we identify people to be able to provide them with a health record and be able to go back if there's a need to provide them with that record or to deal with an adverse event that might occur and to treat them as the people that they are without being able to identify them. And the challenge for us is that many of these people either don't want to or aren't able to or have not been able to engage with the system to get an identity from Home Affairs. So our solution is to create a health-specific record number. So those of us who have IDs will get those record numbers anyway. Through the HPRS, the Health Patient Registration System, we will get an HPRN, Health Patient Registration Number, which will become our file number for the portability of our health record going forward. And what we are working on at the moment for this now during the vaccination program is to pilot how do we use that number for people who have no other identity. It's more complex than it looks on the surface, but we have a project that we've been working on for some time, and that's our intention to use that as our solution. As far as the NHI is concerned and dealing with people, again, I won't comment what's in the bill or whatever might come out of Parliament. But from a practitioner's perspective, let me take you back a few years to when I was a new young doctor in the 80s, 1984, 85, those times. I was working in what is modern day Limpopo, and in those days there were thousands and thousands of migrants coming through the Kruger Park from Mozambique from the war. And we had a malaria control program running along that border that required us as the health services to make sure that people who came across with malaria were treated. But the security forces obviously would want to send them back. And we had to protect our patients against the security forces to make sure that we were able to control the diseases and look after the people. And it extended later to vaccinations against measles and tetanus and all kinds of other, everything else that we were dealing with in the refugee camps at the time. So there are ways to do it. And, I've had personal insights and involvement in this before, and we will find a solution. We will find a way that we can record people and give them proper healthcare.
Thanks, Dr. Crisp. I'm now going to move on to a question that is for you, but also for Tebogo and for Stravos. And that is, someone is asking that we've spoken about areas where collaboration goes better between the private and public healthcare sectors now, but what are the areas that are still very hard to collaborate on? What are the issues that we still need to address much harder? If you can think of two of such areas, what would those be, Dr. Crisp?
We'll always differ on profit. So the health department and those of us who work in the public sector will always regard profit as being a dirty word in healthcare. You know, making a margin to be able to cover your costs and to do so and make a living is not the issue. It's profit. It's where you're working for the shareholder and not for the patient. We have a problem with that. And we will continue to battle to find a middle ground with the private sector. So we don't want to take away autonomy. We don't want to take away people's right to make decisions. We don't want to take away people's choice. But we don't want people making exorbitant profit. And the question is always, where do you set that limit? So we are going to continue to differ on that. We will continue to differ on how you pay for health systems. We don't want a parallel health system. We want one health system where we all contribute to one fund. And you can go to private or public providers, provided they are accredited, they are playing the game, they comply with the conditions of Section 39 of the bill, and they are part of the entity of the total delivery system. Whether one is earning more, the other is earning less, is less of an issue. It's how you wring money out of the system that we will continue to differ on. But there are lots of common grounds. And we don't always differ with everybody. There are large segments of the private provider environment who actually agree with us. They just like the autonomy. They don't want to be part of government. We have no beef with them whatsoever. But when you are spending a lot of money on trying to find ways to create different packages for different people in different pools, to, you know, my health is not equal to your health, we will have a problem with that. So I think we all know that those are the issues, and we all know it's Section 33 of the bill that's going to make or break this relationship. But until then, we actually work as well as we possibly can to use all the resources at our disposal to focus on patient care. And from the government's perspective, that's what we will continue to do. Thanks.
Thank you. Tebogo from Discovery, we don't want a parallel health system, and you are a medical scheme. What do you find is still hard to collaborate about and agree on with government?
Thank you, Mia. Yeah, I think Nick has touched on some of the points of divergence. I think our view is that it's hardly ever binary. I think these things, there's always areas for common ground and solutions that are kind of pragmatic and practical without kind of breaking down everything and saying either or. I think you can have an NHI fund coexisting with other private health insurance, and in a manner that does not undermine the principles in the preamble of the NHI bill in terms of the UHC objectives or the social solidarity imperatives. You can mandate everyone who can to participate and make a contribution to the NHI fund. And I think the issue around Section 33 is really about, once that obligation has been met, do you allow other private citizens to make a contribution, post-tax contribution, to another fund that may contribute, that may coexist with NHI. So I think it's those little practical terms, but as long as the policy objectives, the principles are aligned, I think it's actually possible to make this work. It's very clear to us, the fragmentation in funding and the fragmentation in delivery is problematic, and there are systemic and structural reasons for that, which I don't have the time to go through now, but it's in all our submissions, in our discussions with the department, and in our submissions to the competition commissions. There are very good reasons why some of these complexities exist. But I do think through collaboration, discussion, we can actually achieve the objectives of the policy, of the health policy in this country without, destroying or creating these lines. Thank you.
Thanks to Bogo. Stravos, what are the parts that's still hard to agree on when it comes to Business South Africa?
So Mia, I think both the previous speakers have centered in the real issue here. The perspective of business is that one has to be realistic around private sector businesses, right? No economy can function without having private sector investors investing in infrastructure, investing in services, in human capital, et cetera. So I guess the difference here is a multi-payer system versus a single payer system. And Nick's called it Section 33. It's quite right. And I think that's where we've got to try and find each other. But I think we've got to do that within finding a realistic balance, because you do need to have access to healthcare on the one hand, but on the other hand, we've got to be realistic. And we've seen what happens when people don't invest in your economy. We've seen the economic hardship that creates, and we cannot divorce that from what is required to achieve access to healthcare. So in summary, I think we've got to find each other around balancing realistically how economies work with investors and investing in infrastructure, but on the other hand, also bridging the inequality gaps and ensuring that patients do have access to treatment. I think we find that middle ground. I think we can find each other. Thanks very much.
Thank you very much. It is now 15:30, which was going to be our ending time, but I'm going to let us go on for another 10 minutes so that we can ask 2 or 3 more of your questions, because there are so many. So there's a question from Tanya Faber from the Sunday Times. It's for Dr. Crisp, and I would like for Afrobarometer to also comment on this. So the question is, the vaccine rollout has shown how equity can be achieved to some degree, but will these learnings hold for health issues that don't affect everyone together? In other words, would there be more collaboration on an airborne disease than, for instance, say, maternal health care? Dr. Crisp?
Yeah, well, thank you very much. Tanya's hit the nail on the head. You know, when my health's threatened by the guy who sits next to me in the restaurant, the taxi, or wherever I happen to be, suddenly it's worth my while to invest in that person's health. But when it's HIV or it's pregnancy and some pregnancy-related condition and doesn't affect me directly, it's very hard for me to see why I should share my money. Now, for us, and to partly build on this question and the previous responses, we don't see healthcare as a tradable commodity. We don't see it as an industry. We don't see it as a business. Yes, there's the business of running healthcare, even in government, even in public sector. And I ran a business consulting to public sectors all over Africa for many years. So there's a business. But healthcare itself is a public good. There's lots of evidence from all over the world that if you invest in healthcare, you spend money on healthcare, it's not an expenditure, it's an investment. Because the returns you get on what you're able to do in your economy and in society are immeasurably better. Again, we don't have time to go into that. We can have another discussion about the economics of healthcare and the donut economy of the world. Why chase GDP and profit and paying to people just on profit? Are there not other important things like our health, like our education and ability to engage in the jobs that we need to do to be responsible participants in our economy? So from our perspective, that's why you need a government, and that's why you need leadership within the government and in the department to make sure that we build a system that is not based just on the day that we have a threat that all of us perceives in a common way, but that it's all of us looking after one another because it's important to all of us because we are humanity. And that's really the bottom line. Thank you.
Thank you, Dr. Crisp. Bhekisisa, did you get the idea or perceptions from people in your survey that they trust certain health services more than others? For instance, do they have more faith in COVID health services than general health services?
Thanks, Mia. So one of the questions we asked was actually, do you so you use public or private services, but do you trust the healthcare services that you're utilizing? And across the board, there's no difference around that. I think for a lot of people, it's about whether can I afford to go to pay, can I pay for that service, whether it's public or private? And I think half of the issues that you are seeing around vaccination, for example, have to do with trust in what government has done over the past few years and what has happened. And we shouldn't downplay how much South Africans distrust government because of stories about corruption in the PPE and all those things. It doesn't necessarily mean then that people will not get vaccinated much later. I think it's also key to, when we look at survey data, to realize when was it conducted. So, for example, you've had NEEDS, you've had Ipsos and many other people and ourselves. We conducted a survey in May and June, and there's certain factors in that period that you really have to take into account when interpreting the data. So you're starting phase 2 of the vaccination. We had the stuff about AstraZeneca. We're getting AstraZeneca. Wait, we have to get rid of it now because the date is expiring soon and so on. So people are paying attention. And it's also interesting that South Africans also do say, they know when the government is doing something right and they recognize it and they say it's so. But I think we must never underestimate that trust deficit. It needs to be bridged quite a bit. Until then, you probably get some hesitancy coming up, especially in the 1st of September. See how many, you had 35 to 45-year-olds registered, like 1 million registered in one day. Are you going to see that with younger people than that? So those are things we need to pay attention to in getting a system to work in the bigger scheme of things. Thank you.
Thanks very much, Dr. Crisp. Another question for you. It's from Shrikant Peters from Groote Schuur Hospital. Wants to know, how will the National Health Department ensure criteria for accessing ICU and other restricted tertiary services are standardized across public and private facilities? He didn't specify whether that is just for COVID perhaps or for the NHI. Perhaps you can give us a broad answer.
Yeah, thanks very much. So yeah, unfortunately, that's quite a long answer, but there's a process that one needs to embark on to get to that. The National Health Insurance, like any other national health system or insurance, which you would find in the first world, procures benefits on behalf of the public. So you buy, the fund will have the money, the benefit is defined, and the benefit is, in the case of what we're anticipating in the National Health Insurance Bill, defined in something like a diagnostic-related grouper, and the fund will buy that care. Whether that care is provided in a public or a private setting, the price is set by the fund. There may be differential prices. There's nothing in the bill that would prevent that, and there would be regulations about why one would do that. And the reasons one would do it would be to get strategic purchasing, to shift the way in which patients are serviced within the community, to get equity in service delivery. So, but the bottom line is the fund won't pay 40,000 for the same outcome to a private provider and 10,000 to the public provider. They'll only pay one amount, and those amounts is what will be published. And what that will do is it will stop any provider, public or private, from doing things just to make the money, or by trying to inflate the things, the costs of things, or the price of the services based on an inflated cost here and an inflated cost there with add-ons and administrative costs and so forth, and then a profit margin on the top. That price structuring is something that people have now just complained about, not wanting the committee that is described in the bill to be appointed by the minister. And maybe that's a point. Maybe it does need to be appointed by somebody else, but you still need a committee that does that price setting, so we all know that for this particular outcome, this is what the government is going to pay, and it's going to use my taxpayers' money, which is just put in the National Health Insurance Fund. Then with our data that we've all been talking about, we monitor who does what. And if we see that there's a particular service or person, we call them establishments or individual providers, we would then see who's providing what. And you pick up the trends of this person is seeing 40%, 50%, 60% of all deliveries being Caesars, but that one's only doing 10, 15, 20%. What is going on here? And you start to investigate to see whether it's the good clinical practice that's at play, or whether it is some other kind of convenience service that's being provided. I'm just giving those as examples. There are hundreds of those examples that we could use of how you monitor the data and you flag it in the system to prevent fraud and corruption and to highlight bad practice and then to address it. Anyway, as I said, it's a long discussion. Thank you.
Thank you. There is a question that I would like you, Dr. Crisp, and also Stavros to comment on, and that is, someone wants to know, so we had evaluation of health facilities in the country by the Office of Health Standards Compliance, I think it was 2 years ago, and many of the facilities, particularly public health facilities, were found to not be up to standard. Now, what will happen to those facilities? How can they be part of the NHI? I would like to know from you, and from Stavros, I would like to know, is there a role for business to play to upgrade those facilities? Dr. Chris, let's start with you.
Okay, thanks very much, and you'll give Stavros the last word. So that's fine. We acknowledge there's a lot there. Look, there are very good services in the public service, and one must not for a minute think that the entire public service is a mess. We've seen a large number of people going for vaccinations in the public service who are on medical schemes being overwhelmed with what they have seen and quite surprised. So we're happy that that has happened, and it's good that people see that not all the public service is bad. But there are parts of the public service which are horrendous, and we see them, and it's an embarrassment, and it needs to be fixed. So it's not that government's trying to hide that there are some services and some facilities that are, just way below par and totally unacceptable. So the answer to the question is that there's a national quality health improvement plan it's commenced. It's in baby shoes at the moment. It's working in 18 sites, looking at a multiplicity of different facilities from big hospitals right the way down to clinics within a geographical area, sort of within a referral space, let's call it, and looking at building the system to improve quality. So some of them are actually quite reasonable quality, and others are deliberately targeted because their quality is not very good. And the idea is to watch, what do you need to invest in to get, first of all, to the basic first step of the Office of Health Standards Compliance current standards, and then to move beyond that with quality improvement plans that take each facility and the components of the services within that facility one step more, but that it becomes a constant practice and not something you do because the inspector's coming. And then those sites will be used as the training sites for the facilities around them. And Stavros can comment, but part of this design of this program is to include private facilities, GP practices, small hospitals in the private sector. And there have already been several, in fact, all of the major hospital groups have approached us and said, we want to be part of the improvement of this quality, not just for our own facilities, but elsewhere. So that's the kind of collaboration that I see going forward. And if we can just find more time once the vaccination program's going, that's what I really came to do, to build on. Thanks.
Stavros, how can business help?
Yeah, firstly, I think we've got to work off a premise that when you say you want to equalize healthcare or narrow the inequality gap, it doesn't mean pulling down the standard overall, right? We should aspire to keep a certain level of healthcare so that you do in fact achieve that equalization. Now that's going to be best achieved if you're able to properly invest across infrastructure, human capital, and all the other things, IT systems. I mean, our IT systems, for example, are hugely underinvested in, undercapacitated. So to get there, you are going to require ongoing investment from the private sector. And that was the point I was trying to make earlier, that investors will want, and I'm being realistic here, investors will want a certain return capital. You might redefine or recalibrate that in healthcare. I think that's fine, and it's a debate that's got to be held. But you can only get to having the type of infrastructure you need in the country if private business comes in and makes these investments. Where they make the investments, whether it's in the private or the public sector, is a point that needs to be debated further. But I think under the right set of circumstances, I can't see that the private sector would not want to make some type of investment in overall infrastructure that covers public sector patients as well. And I think to get there, we've just got to be realistic, as I said, around both the fiscal position of the country and then also around how do we equalize healthcare without pulling it down overall. Thanks very much.
Thanks, Travos. I'm going to end with the last question because there's been so many questions about corruption and how do we prevent corruption in the NHI. And I'm going to ask Umunyana to respond, and then we can end with Dr. Crisp's response to Umunyana's response, because civil society has had a lot to say about what needs to change in the NHI bill in order to prevent corruption. So Umunyana, can you give us ideas around about what Section 27 thinks we should do, and then we can end with Dr. Crisp's response.
Thank you, Mia. I think that on corruption, we have to ensure that at every level, from the most localized level to national, that the systems are in place to ensure that we don't have errors where we're paying 10 times the price that we should be paying, which has happened in Gauteng, for example, that we're not seeing the kinds of errors that really cost us in the millions. And that's errors, but also dealing with corruption. So we need those kind of IT systems, the infrastructure systems that both Stavros and Dr. Crisp have spoken about at each level. But we also need to invest in capacitating the managers at health facilities, the management in the provinces. We know from the Auditor General that it's very difficult for provinces to absorb money that is allocated to them, to simply absorb it and deliver the services. The COVID grant, for example, there was 1.8 billion allocated by Treasury, and the municipalities only spent just over 500 million of that on the COVID response. So there's just an inability to be agile and to respond to emergencies, but it really is an endemic issue. And we need to see investments at that level as well in order to address corruption and maladministration. And again, consequence management, where there are issues, we need to see consequences. We need to see disciplinary procedures that don't take 18 months. People really want to see the trust improved between the public and the government. Thanks.
Thanks, Umunyana. Dr. Crisp?
Yeah, so thanks very much. Umunyana is absolutely right. I mean, it's if we, as the citizens of the country, don't stand up and stamp out corruption, it's going to just continue. But from an official perspective and from within the system, you have to have a multi-prong approach. First of all, you've got to abhor corruption. You really do have to have zero tolerance and be very angry about it. Otherwise, it will just happen around you and you tolerate it. That's the starting point. Then you have to design your systems that it's hard to corrupt them. And we have in the NHI a fraud and corruption unit that will be one of the first now with the first posts, where the objective of the people we employ there is to make sure that they are looking at the design, watching every 5 minutes. Right now on the vaccine program, the Auditor General is with us all the time, asking questions. What are your governance procedures? How are you doing this? How are you preventing that? What have you done to prevent X, Y, and Z? How did you respond to such and such a thing? We have to have that kind of diligence within the system that we are building. We know that patients defraud medical schemes every day. Why would they not defraud the NHI? We know that practitioners defraud the schemes every day. Why would they not continue to defraud the NHI? We know that companies try to defraud in the way that they provide goods and services to the public and the private sector. So what would change? So we have to design the systems that we flag any kind of aberrant behavior. So you set up rules and you say, if anybody operates outside of these rules, investigate it. Put the flag up. If you try and come twice for your tablets in the month, why did you do that? Who are you giving them to? Who is the practitioner who's prescribing outside of the clinical guideline, and do they have a reason to do it? Because if they do it once, it's fine. There might well be a reason, and you will talk to them about, and you will hear the answer. But if it's repeated behavior, who are they supplying those medicines to? So everywhere within the system, we have to design and use the technology at our disposal to prevent, to recognize the risk and prevent the fraud. Then we need to have, when people get around the systems, because they do, make no mistake, people are hacking systems and doing things all the time that are wrong. You have to have absolute vigilance that you act now. So when I get a phone call to say, hey, we picked up that vaccine is being sold on XYZ street corner, within 5 minutes, the hawks know about that. Whether they respond within another 5 minutes or whatever, it's beyond my mandate, but they know within 5 minutes what is going on. They know the address, they know what's got to be done, etc. And the same must happen when we pick up that somebody pinched a sheet from a hospital and walked out with it. Everywhere, theft, fraud, corruption, we have to not tolerate it. And then Umanyana said it, there must be consequences. You have to make public what is going on and you have to deal with it decisively. Now that happens at an administrative level, it happens within committees, it will happen at at political levels. We've lived through a lot of tough times recently in the health department, as everybody is aware. But there have to be consequences, otherwise we will never get the trust of people. But if you don't stand up and deal with these things, if you just complain and you don't party to whistleblowing or bringing it to their attention, nothing will change. And we'll continue to moan and bemoan the fate of our country. And I don't think that's the right way to go. I think we must take the bull by the horns and we've got to start one by one addressing these unacceptable behaviors. Thank you.
Thank you very much, Dr. Chris. That's a great way to end on, and such commitment from someone from government that we really need to fight corruption. I would like to end with a comment that someone was made that I think summarizes pretty well where we're at and where we need to go to and work towards to. And that says, South Africa works well together in crisis. There is cooperation and humanity, and it is a pity that we cannot ask to be in a crisis all the time. So in short, we cannot measure our efficiency, and this is how well private and public sectors work together. We can't measure that during a crisis. We need to also extend that to normal circumstances and go beyond this. And I think that is perhaps what we need to do with COVID when we get to universal access to healthcare, to make sure that we can use the lessons in a broader context. I would like to really thank all our panelists. I know that you all are employed in really important positions at your institutions, which makes it really hard to give your time for such a long time, so today as the webinar, and to also share your expertise. But by doing that, you are contributing to a better healthcare system in South Africa, because what we heard today, the media, policymakers and people who have joined this webinar can use to think about what is the best way to go towards to universal access to healthcare in South Africa. So we'd really like to thank you for that. And also, if you would like to have a recording of this webinar, we have a recording on our website, Bhekisisa.org, but we will also be sending out an email tomorrow to all of you, which will include a link to the webinar if you wanted to listen to it again. And there will also be a short survey in there. It's about 2 to 3 minutes to complete it. It will just help us to know what we can do better and what we've done well, so that we can make sure we have webinars that work for you. We would very much appreciate it if you do fill it in. And from Bhekisisa, we would really like to thank all of you for your time and for your participation, and hope that you have a good day further. Goodbye.